Welcome to H360 Health Talk. We're here today with Dr. Sophie Bartsich and Dr. Kathleen Ruddy in the second of a four-part series on breast cancer. Dr. Sophie was born in New York City and groomed in the sciences at a very early age, completing her undergraduate degree in psychology at Cornell University with a focus on behavioral and interpersonal relationships. Compelled by a growing interest in design, she then attended the Parsons School of Design while working at the fashion house of Calvin Klein. Realizing she wanted to become a physician, she completed her studies at Columbia University and got her medical degree from the Weill Cornell Medical College of New York. Dr. Sophie was then accepted into the independent program in plastic surgery at New York Presbyterian Hospital. She's also the chief of staff of plastic surgery at New York Presbyterian Lower Manhattan Hospital. Today, she's a plastic surgeon specializing in breast reconstructive surgery for mastectomy patients. Dr. Ruddy, author of the bestseller, The End of Breast Cancer, A Virus and the Hope for a Vaccine, is an internationally recognized breast cancer expert, founder and medical director of the breast services at Clarimass Medical Center in Bellevue, New Jersey, founder and president of the Breast Health and Healing, her private practice in New Jersey, founder and executive director of the Breast and Health Healing Foundation, and creator of the ongoing Pink Virus Project. In 2010, Dr. Ruddy launched her first mobile app, Breast Health GPS, where GPS technology is used to locate the nearest certified mammogram screening center and connect those individuals with her website, her blog, and her other networking sites. Her most recent app, Lobby Me Pink, provides contact information for U.S. senators and congresspeople and allows the users to send emails directly to their chiefs of staff and health policy advisors for every member on Capitol Hill. Better Homes and Gardens names it one of the 6 most important innovations in the fight against breast cancer. She is also on the Leadership Council of Harvard School of Public Health, and today she sees patients in her private practice in New Jersey. Welcome, doctors. Thanks for joining us. The second in a four-part series, we talked in the first part about prevention. We want to talk about diagnosis. We're going to follow that up in the next segment with treatment. We have a lot to talk about today. But let's recap. We talked about diet. We talked about cultures. We talked about a lot of things in the prevention of breast cancer. In the area of diagnosis, what do we see in terms of new innovations? We have mammograms, we have ultrasounds. Do we see anything new in the area of innovation coming for diagnosis?
There's hope that we might be able to find circulating tumor cells in the bloodstream. So we know the typical breast cancer, not all of them, the typical breast cancer will be incubating for about 5 years, growing slowly before it can be seen on a mammogram, and then maybe another 5 years before it could be felt by a clinician or the patient. Although, as I say, there are some tumors that grow very quickly in between mammograms. They just weren't there, and now they are. Inflammatory breast cancer would be one of them. Because mammogram screening is not efficient and very costly, and there's some good challenges to the efficacy of finding and treating all breast cancers that are found based on mammogram screening, other ways of diagnosing breast cancer and other cancers early have been undertaken, and one of them is to look for circulating tumor cells. So cancer by definition, even if there are only 2 cancer cells, by definition what makes those cells malignant is the fact, one of the 3 basically characteristics is that those cells have the ability to metastasize, to move from where it was growing somewhere else in the body, metastatic potential. And one of the places that you'll find them, typically you'll find them in the bone marrow. Over 90% of women who have little teeny tiny tumors in their breasts will have breast cancer cells in their bone marrow, the majority. You can also find them if you look closely in the bloodstream. These are the circulating cancer cells, the circulating breast cancer cells. The problem is they're really hard to find. And that technology has not been sufficiently refined so that it is both effective and cost effective. You'll read a lot about it, you'll hear a lot about it, keep your radar dish open for it. I don't think that's where we are right now. Where we are is where we've been for 30 years. The best screening modality that we have for finding breast cancer, and it's not all that great, but it's the best we have. It's the only thing we really have is mammogram screening.
Got it. So, Dr. Sophie, in terms of mammograms, we're told, for example, in colon cancer, right, if you're Lynch positive, you demonstrate that genetic mutation, and you have colon cancer in your family, the rule of thumb is colonoscopy 10 years prior to that person in your family that's been diagnosed. So if my father was diagnosed at 40, I should be having a colonoscopy at the age of 30. What's the rule of thumb in breast cancer? And you know, I hear BRCA, right, which is the genetic mutation similar to Lynch in colon. What's the rule of thumb? And do people realize that they are even BRCA positive?
I don't think that there is a rule of thumb. I think that there are formal guidelines, as with anything else, but I don't think that if you, and I know this because I've done this, if you speak in isolation to multiple different kinds of physicians, gynecologists, breast surgeons, oncologists, radiologists who read mammograms, which I've done because as a woman who's now over 40, I've done this in my 30s, and I was training and I was in residency, and I started to see, you know, when I was in medical school, the patients with breast cancer were in their 60s and 70s, then they were in their 50s, then I was a resident and I saw a couple in their 40s, then I saw a couple in their 30s, and I said, what is happening? And I started going around and asking my colleagues, and I started saying, listen, I know there's a formal recommendation, but what would you do? What do you tell your relatives to do? What do you tell your aunt and your sister and your mom? At what age are you starting? When should I start? What does this mean? And I think that there's still just not, there's no real rule of thumb, it seems. I think the people who see a lot of it and are very scared of it tend to start earlier. I know for me, I did my first mammogram when I was 35 just to get a baseline. I think the baseline concept is very important. When you do any test, they're always going to look back and say, well, what was the last one like? So I don't know that you necessarily need to start when you're 25 and do them every year. I wouldn't advocate for that. But I think having a baseline is a good idea. I think it's very important to know in general where you fall in the risk stratification, because that's also, like with colon cancer, going to be relevant. I think most people do not know their genetic status in terms of BRCA, but it's also not the only genetic risk factor. There are many others, and there are more emerging and more we're learning about. So even if you did go and say, you know, I want to do a BRCA test for myself, if you're negative, it doesn't mean you don't have a genetic predisposition. It just means you don't have that one.
I think there was something like 40 new genetic
Yes.
predispositions that are coming out for breast cancer.
There are a lot, so that's also confounding. So, you know, you might say, well, I don't have that, so I'm okay, or I don't know of any female relatives. Maybe you don't have any female relatives, or you don't know them well enough to know their story. As a general rule, it seems like 40 is sort of the magic number to at least have had a baseline and start looking. I also personally, I've thought about this for myself a lot as well. I feel like every year for someone who's low risk might be a lot. It also depends on how good a test it is for you. So the mammogram is pretty much what we have, and it's not as good a test for everyone. That's the other part of it. For some people it's a great test, and for some people it's not so great. So for whom is it not so great? Someone who has very, very dense breast tissue and not a lot of it. It's not a great test. The result will always come back saying we need to do more. We need to do an ultrasound as well. So I think what confuses a lot of patients is, well, why all these different tests, and what do they each do that the others don't? So trying to kind of demystify that a little bit. The mammogram is an X-ray, basically. and x-rays see calcium. And calcium tends to deposit in tissue that has a problem like a tumor. So the mammogram is really looking for calcium in the tissues as a guide that maybe there's a problem. And even if there is calcium, it might not necessarily mean you have cancer, but that's what it's looking for. And there are no, at least to my understanding, no other tests that can really effectively find those little tiny bits of calcium that might signal a problem. Mm-hmm. The ultrasound looks at tissue density, which is very different. It's not going to find the calcium. So it can't really substitute for the mammogram, but it complements it. And then the next level is the MRI, which takes a long time to do, is expensive, might not always get covered, is also for some people a very difficult exam to undergo because you basically feel like you're in a coffin, you're in that little tube for 40 minutes with it screaming at you. And the issue with the MRI is it's actually such a sensitive test that it tends to pick up a lot of things that might be an issue but that aren't. So it can get you sort of down this long road to, oh, it was nothing, but that was a really horrible 6 months. So that's the danger. It's also a huge expense on the system, and it's very taxing psychologically. So I don't think anyone recommends everyone should just go get an MRI. It tends to happen when the other tests are not enough. But one of the things in plastic surgery they say is if there's 10 different ways to do something, it means there's no one good way. Mm-hmm. So there are several different exams. They all do different things. The standard of care is still the mammogram, but often it needs to be complemented by other exams. And I don't think there is, for any given person, a real definitive rule. You should start at this age, you should do it every this much time, and that's going to do it for you. So we work with what we have and with the guidelines.
Yeah, none of them are certainly perfect. In my personal life, I've gone through all three of them. And with the MRI, I had breast cancer on my right breast, and the MRI picked up something on the left one, which of course scared everybody. And after a biopsy, it turned out that was just PASH. And so, of course, you don't need to go through that fear again. But I have dense breast tissue, so an MRI is probably better for me. So speaking of dense breast tissue, are there different levels of density in the breast, and how does that affect these diagnostic tools?
There are degrees of density. There are dense breasts, and then there are heterogeneously dense breasts, which are, just impossible to assess with any accuracy as to whether there's something in there or not. Because, a mammogram, you compress the breast. It's almost like compressing a filing cabinet and taking a picture at one end of the filing cabinet, the film is at the other end, and you're like, is there a toy soldier in there or not? That's what the mammogram is like. Okay, well, let's look at it up and down. Is there a toy soldier in there or not? And if it's very dense, if that filing cabinet is every piece of paper that you've ever owned in your life, including some of the toys, you're going to have a hard time saying, is that a cancer, is that not? So there are degrees of density seen on mammography, and when, at least in New Jersey, when the radiologist has identified a heterogeneously dense breast mammogram, then additional studies like breast ultrasound and even breast MRI, if there's a family history, can be ordered and are covered, and it's reasonable to do that.
And that's for every other mammogram you should have throughout your life if you have dense breasts?
Well, I think the screening recommendations, I think, are sound based on the data and based on my experience, which is to have a mammogram every year. So I'll just give you a story, and you really only need one story to be able to argue for the validity of it. A colleague of mine who's a radiologist, she gets her mammograms every year, and she had her mammogram, say, in April, and 4 months later she called me and she said, can I talk to you? I said, of course, I talk to her all the time. And she said, no, me. She said, I found a lump in my breast, and I did the ultrasound. I have a lump in my breast. And I redid the mammogram, and the mammogram shows the lump in my breast, and it was a cancer. So the reason, you have a mammogram every year is because in that 12-month interval, there can be a visual change, or there can be an eruption of a cancer. So mammogram screening every year, and if the mammogram does not provide an image which the radiologist feels is satisfactory for ruling out anything that might be hidden, then a breast ultrasound, a breast MRI is warranted.
So, no rule of thumb. There's some guidelines that we can follow in terms of age. What about things like 23andMe, right? You see this whole DNA sequencing and, you swab and you send it away. Is that going to pick anything up? It probably is difficult. If you don't have breast cancer in your family, you're not going to run out and say, look, I want to be tested for BRCA or the other 40 things that, could lead you to breast cancer. Talk to me about the 23andMe or things like that. Is that positive? Is that negative? Is it confusing?
Sure. I don't advise anyone to medically treat themselves over mail order. I just don't think that's probably the best way to do it. Especially with genetic testing, it's so complicated, it's so layered, it's so intense, it's so emotionally charged. When I was pregnant, we decided to do this very involved genetic test just because in my world, everybody has a problem and I wanted to check. And they wouldn't let us do the test without having a couple of meetings with a genetic counselor. Yeah. Because you have to have someone guiding you. These things cannot be self-diagnosed. They can't happen in a vacuum. There's too much involved, and people can make their own associations and draw their own conclusions erroneously very quickly, and then start making other bad decisions afterwards. So I think the whole 23andMe is very interesting. I've thought about it. I've discussed it with friends and with family, and I have a little bit of a conspiracy theory thing with it anyway going on, that they're really just trying to gather all this information, and then ultimately one day in 20 years you're not going to be able to do something because someone knows something about you don't want them to know. So I steer clear of it because I don't need anybody looking into my genetics. But definitely it's marketed in such a way that I think people might consider it a substitute to having a conversation with a person who's medically educated and able to kind of mitigate all the emotions that go through it and guide them and keep the reason in the equation. So I think it's probably a fun experiment. It's potentially something that you might regret one day, maybe. I don't know. But it doesn't in any way, it should not replace a conversation with your doctor and properly medically guided treatment, counseling, and diagnosis. So, but yeah, it's just like the internet. It's a big can of worms. There's some good in it, and there's also a lot of potential for bad.
Yeah.
Could I just add a thought to that? In sort of pulling back and reframing what we know about that second piece of the equation. So the first piece of the equation is the breast cancer virus, and the second piece is the genes, the genetic predisposition. So let's look at a BRCA mutation. And we know there's no question, okay, if you carry a BRCA mutation, you are at an increased risk for breast cancer. 50% by age 50 in general. In some kinds of variations of a BRCA mutation, 85% lifetime risk of breast cancer. And those data are based on lots of information. But 15% of the women who have the mutation never get the breast cancer. And 50% of them by the age of 50 don't get the breast cancer. So even if you have the gene that you know increases your risk for breast cancer beyond everything else that we understand, it doesn't mean you're going to get the breast cancer. So then if you throw into the equation 23andMe, and you have, even if you're collecting a lot of information about this spectrum, this gene array, which puts you at an increased risk for this, that, and the other, and let's say you can just identify some of these fuzzy things in the middle that may be related to breast cancer, what are the interventions, what are the real risks, and what can you do with that information? You know, there's a famous thing in medical school and in the practice of medicine, don't give me a piece of information I can't use, okay? Unless I can use it, I'm going to be distracted. Just give me the information that I know I can use. And I don't think that we know enough about the 23andMe. As well-intentioned, we're going to benefit of the doubt. We're going to assume that they're well-intentioned, okay? I don't think we have enough information about 23andMe and those kinds of tests, especially in the face of what we know about the BRCA mutation, to be able to say, oh, we can recommend that as information that might be helpful to you? I don't think so, not yet.
I think the genetic testing, especially the mail order, certainly is a can of worms. And there are some services out there that do pair you with a genetic counselor. I had to go through the genetic testing when I was first diagnosed, and I talked with a genetic counselor. It was very helpful. But I think for some people who maybe don't know their genetic medical history, say people who are adopted or potentially in, getting out of foster care situations, and they don't know that I had a woman in my family who had breast cancer or a father who had colon cancer. I think knowing that and knowing, maybe I should get screened for certain things earlier is much helpful. I think about it a lot, and I talk to my siblings about it a lot because I have 2 siblings who are adopted. And so when I was going through all this, I was talking with them about it much more, saying, I want everyone to be happy and healthy, and we should know if you need to be screened for certain things earlier. But speaking of screening, they do carry some risks with them. So is there risk associated with mammograms, ultrasound, MRIs, things like that?
Yes. Well, I mean, yes, in terms of, again, what can you do, should you do with the information? So a large study published several years ago showed very well that as much as a third of the breast cancers that were diagnosed based on mammogram screening did not need to be treated. The conclusion, which I disagree with, 2 conclusions. One was that there was overdiagnosis. I strongly disagree with that assessment. These were breast cancers. The pathologists did not get this wrong. It's not a matter of overdiagnosis. It's a matter of we do not know which of these cancers require treatment. And in the retrospective study that was done, which was good and sound, good epidemiologic methodology, it appears that a third of those cancers did not need treatment. If they were never found, patients would be fine. They'd die in their sleep at the age of 100. So the hazard of mammogram screening, a very real hazard, is that you might be diagnosed with a real cancer, not overdiagnosed, diagnosed with a real cancer that requires no treatment. Now here's the final statement as of today. We do not know which of those tumors do you have the one that needs to be treated? Do you not? It's going to threaten your life. I'm fine, okay? Until we get that far down the road, and until we have another screening method, the best screening method we have is mammogram screening. It's the only one we have. And if you are diagnosed with breast cancer, you're diagnosed with breast cancer. Get a second opinion if you have any questions, but you're diagnosed with breast cancer. And then we are compelled, as a medical profession and as patients, to do what we can to treat it, knowing that, wouldn't it be nice if we could sort through the 1/3 of patients who don't need to be treated?
So what would be the deciding factor of this cancer doesn't need to be treated?
We don't know yet. And so my greatest grief when I was actually invited to debate the author of the study was that women in the world are going to look at the headline, crawl across the bottom of Bloomberg News, 1/3 of the breast cancers never need to be treated. And they're going to think, I was treated for a cancer that would never have bothered me. You can't tell me whether I had the tumor that needs to be treated. You're just saying that 1 million women in this country, perhaps, have been treated for cancers unnecessarily. Do not do that, okay? Do not do that, okay? Allow a fuller conversation and say, we need a better screening method, and what we need is a better way of assessing those tumors. Look at it under the microscope. Do your little, magical gene array analysis. Tell us, what can you tell us about this tumor versus this tumor? This tumor does not need to be treated. We could follow this woman expectantly, perhaps just give her some kind of anti-estrogen or what have you. This one looks like she should be treated. That's where we need to go with that.
Right.
Well, we do know that early detection saves lives, and it leads me to self-exams.
Yes, I was hoping you'd go there.
Yeah, and I'm a big advocate of that. I personally do a self-exam once a month. you know, again, we're talking about breast cancer and we're leaving out male breast cancer here. So, you know, talk to me a little bit about that. And I know,
Yeah.
you know, there's some, you know, guidelines that females should do it at a certain time every month, and you know, because their bodies change over the
Yeah.
month, and men, other, you know, differently.
So echoing something you said is, you know, give me some information you can use. I feel like give me something to do that I know how to do is the thing with self-exams. We tell women to examine and we tell men to examine, but how often does someone get taught how to do it? I think that's one of the main problems. And there are probably a lot of women who feel like they are examining themselves, but they might not be doing it the way that they're supposed to or as thoroughly as they should. There are also a lot of women who use their gynecologist as their primary care doctor, and that's who does their breast exam every time they get an exam. And it's nothing against the gynecologist. They do a lot of exams, but they're not all doing the same kind of exam either themselves. And so there's a lot of variability in that as well. So we've talked a lot about the imaging tests, and a lot of what we do in medicine today is computers. You know, people don't look at the patient, they look at the screen, and they look at the numbers and they look at the tests. And there's a lot to say for the history and physical exam, old school medicine. There's a lot to say for clinical exam. And a lot of breast cancers are picked up by self-exam or by the partner of that patient who finds something that doesn't feel normal. And I think you have to keep that in mind. It's not just the mammogram and the ultrasound or the MRI. The self-exam is a whole other diagnostic tool. And I think it should be seen as that. It's a diagnostic tool, and it's like any other tool. If you use it the right way, it'll be very effective for you. If you don't use it the right way, you can't expect it to work. And if you look at a lot of communities in Europe, there are a lot of places where people don't do mammograms every year. The healthcare system just can't afford it, can't support it. So they are very involved and invested in the self-exam because that's their main diagnostic tool. And in 2014, there actually was a paper that came out that ruffled a lot of feathers that said that they were comparing in cancer, we talk about the 5-year survival, and they were comparing 5-year survivals in these areas where people did not do as many mammograms as we do in the US. They did a lot of ultrasound and self-exam, and they compared it to communities in the US that do a lot of mammogram, and the 5-year survivals were comparable. And some of that is probably because if you do a really good self-exam, you pick up a lot of stuff. And some of it is probably because some of the cancers that were not found never really needed to be treated in the first place. We wish we could know which ones they were, but we don't. There's probably a lot of reasons why. But it's a very powerful message that even without the mammograms all the time, there are ways to get almost to the same verdict, almost the same success rate. So I think it's very important to separate out what is a diagnostic technological screening method and what is other parts of medical care, other parts of healthcare in general, which is the clinical. How do you feel? Do you feel different? Do you think something's wrong? That's also important. How's your lifestyle overall? Are you examining? Is someone looking, listening, and feeling and like really in tune to whether something seems different? And that gets lost because now we're so technology driven, we forget to just look at the patient, talk to the patient, and have the patient, who knows her own body best, tell us if something seems different, and then to listen to that.
Yeah.
Yeah.
Good point. Doctors, thanks so much again for coming in.
Thank you.
Our next discussion will be on treatment. I'm looking forward to that. Again, H360 Health Talk, thank you for joining.